Hello, everyone. This is Dr. Khan, Executive Plastic Surgery. A pleasure to be on another Facebook Live, YouTube Live, TikTok, and Instagram Live. So, a pleasure to talk to you all about what is a very important topic and talking more about implants. And again, the take-home message today is all about informed consent, which means what are you signing up for? I did like a short video earlier this morning where I talk about, the risk versus benefits of doing fat grafting. So as you will see, there are risks with even a lift operation. So I want you to go ahead and see that short video where you will see what exactly it entails where a mastopexy is done, where you cut around the nipple areola and you basically cut up and down from the nipple areola down to the inframammary crease. And then all the dissection that is done, as you can see firsthand, the involved nature of the surgery, where so mastopexy essentially means where the breast tissue, mastopexy means it's lifted up, and it's not it's an excess skin problem where you're essentially doing the lift. And because of the skin and the way it's cut out and the sutures are placed, the patients themselves, when the surgery is done, you can have what is altered sensation around the nipple, pins and needle sensation in the cold weather. Some patients report they're more sensitive, if you will. Some patients are not able to nurse, for example, after a small subset of patients. Some patients feel irregular masses because it might be fat necrosis or scar tissue as a result of the dissection around the nipple areola and inferiorly. The nerve ducts might and certainly can be affected in small subset. Sometimes fat necrosis occurs. And remember, in the US, 1 out of 8 or 9 women will get breast cancer. And when the self-monthly breast exam is done or the mammogram is done, you will have these irregularities that might be just scar tissue that might show up and might unnecessarily basically result in more imaging or biopsies or anxiety if this is a breast cancer or a mass that needs to be followed more routinely via mammogram, ultrasound, or MRI. So the point here is these are relatively not benign procedures, and before you sign up for a procedure like this, you want to see exactly what the surgery is, and I would recommend you go to YouTube and type in mastopexy after explant or just a mastopexy alone, be it an S lift or a J lift, just so that you see. The other thing I want to point out here is in my surgical technique, I make an incision horizontal at the inframammary crease. And this is the crease that's at the bottom of the breast, an incision that patients don't see. And this is horizontal, parallel to the ribs. And remember, when the implant is sitting on the rib, the surgeon has to be able to visualize and see the entirety of the rib that on which the dissection is occurring. And ultimately, this is the take-home message. The surgeon must show a video of the chest wall showing complete removal of the capsule and that there is no capsular tissue or inflamed tissue remaining behind, that there was no spillage of the silicone, and that you have that visual high definition videos and pictures showing complete removal of the capsule. Words alone, unfortunately, are not enough, or on the table cutting open of the capsule, I find is not good enough either, because there are sometimes secondary capsules that form. And so it is important that you must require your surgeon to show you high definition videos and pictures of what remains after the implant and the capsule has been removed. And it is very important for you to see that. If someone were to get a gallbladder out, who cares? Because the gallbladder is out and it cannot be left behind, right? In this case, if you go to 10 different plastic surgeons, you're going to have 10 different surgical cuts, techniques, approaches, thought processes, and it is extremely important that the surgeon is completely, sincerely, wholeheartedly, religiously, honestly devoted to removing the whole capsular tissue plus the inflamed tissue around. And the implant is what is called en bloc, which is removal without any break in the capsule, or 100% total capsulectomy, so that you get the complete chance for recovery. And this is very important for you to ask and make sure it's documented on the consent form, because that's a medical legal document that you are requiring your surgeon to present high definition videos, pictures of not only the cutting open on the table, but also off the chest wall. Like I said earlier, you need to make sure that the length of time allocated for the surgery is not going to be like 90 minutes, but plus minus 4 hours, because that's how long it takes. And as you will see, in majority of the cases, a lift is truly not required. I have not used drains in well over 5.5 years, since 2020 easily. That was the last time I used a drain, because I'm able to do all these complex surgeries, even with the many spilled silicone implants, without the need for the drain. The other thing I want to mention here is, fat grafting, as I mentioned at the very beginning, is also a relatively involved, and I use the word risky procedure. So in my practice, I'm not a fan of fat grafting. I call that malpractice. 1 out of 8 or 9 women will get breast cancer, and in the U.S. In their lifetime. And so you want to be able to do a self-monthly breast exam looking for any irregular masses. Now, when fat grafting is done, typically anywhere from 50 to 150 cc's, depending on the volume, technique, the surgeon's equipment that was used, that the Coleman technique being the best one, you will see that fat does take in the areas that it was grafted to. So that is the desired goal. But then a good percentage of the fat gets absorbed, and a small percentage of the fat will basically inevitably deposit as nodular fat or irregular fat or fat necrosis, or nodules of fat that may form because they did not get the adequate blood supply as they were transferred and spaced out through the breast tissue. And now when you do a self-monthly breast exam, you're going to see that that's going to be altered. The imaging can also be altered. You will see some patients have oil cysts. They have pins and needle sensation, altered sensation as a result of the fat grafting. Some patients have scar tissue that forms because of the technique and the way that fat was injected in and around the breast tissue area. And you may have irregularities, asymmetry that may result from one side to the other. This is where infection has also noted to occur. And so these are, overall speaking, not benign procedures. So you, as a patient, need to understand what exactly is a mastopexy. Go to YouTube and type it in and see exactly the way the different techniques are. Fat grafting, same thing. And so you know exactly what you're signing up for. It's not as simple as, I find, unfortunately, you go to a surgeon's website, you see the best 10 pictures, sometimes Photoshop, sometimes they're out of this bank of pictures that the surgeon did not even operate. It's a bank of pictures that the websites put to show exemplary patients, model patients. And so you want to make sure that, you're not basically convinced by basically saying that you're going to be the 11th person on that list. And so the human psyche and mind, you want to understand what are the risk versus benefits. So yesterday I had a patient, and we're going to post this patient testimony. She, a young lady in her 30s, and she had 695 cc implants, and she truly did not need drains, and she truly did not need a lift. And you're going to hear it directly from her own words, day 8 from her surgery, and we'll see even many months out, a year out. The other thing I want to mention here is, and this is again hard evidence that we know exists, this is not like questionable. This is again out of guidance for industry and Food Drug Administration staff. Breast implants, certain labeling recommendations to improve patient communication. This was basically put forth, and as you will see, guidance for industry, Food Drug Administration, FDA. This draft of this document was issued on October 24, 2019. What's interesting is this week, one of my very old friends from medical school called me up and said, "Oh, you're really doing a lot of these explants." And, he was asking and questioning the fact. Then I told him as simple as this: these are not my words, these are the words of the FDA. Breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery. I just saw a patient that I'm going to be operating on Tuesday, and she told me that her surgeon had said that her implants would last a lifetime, that you can drive a car over the implants. Now, if you will see, if you follow me on Facebook Live or YouTube Live or Instagram Live, you will see that these implants certainly do rupture, and they are very not lifetime devices. And then very small association of the BIALCL. The other thing I want to mention here is patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. Individual patient risk for developing these symptoms has not been well established. Some patients report complete resolution of symptoms when the implants are removed without replacement. So the first thing to acknowledge here is that breast implant illness does exist. Systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, which is the most common symptom, autoimmune diseases. So it does exist because they're telling you, and that there is, quote, complete resolution. That means cure of symptoms when the implants are removed without replacement. This is the black box warning. And the other thing I want to highlight here, this is another verbiage in that consent form, because remember, this consent, they want the patient's initials that the surgeons did discuss with the patients. I understand, and this is the consent form, I understand that some patients have received, who have received breast implants have reported a variety of systemic symptoms, including joint pain, which are the hallmark features of breast implant illness, fatigue, rash, memory loss, brain fog, and that some patients have called breast implant illness. While the causes of these symptoms are unclear, some patients have reported relief of these symptoms with the removal of the implants and surrounding scar tissue capsule. So they're telling you that is part of the heal. However, not all patients may experience improvement in their symptoms. Now, this is certainly very true. Not all patients will notice improvement. And as you will see, they want the patient's initials. The other thing I want to mention here that they clearly highlight, and this is on the next page, and they want you to initialize patient initials, that the surgeon has discussed this with you. I understand that silicone can migrate from my implant into nearby tissues, chest wall, lymph nodes under the arms, and organs, liver, lungs, where it may not be possible to remove. And then it also says, I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer. Mammography can also cause the breast implant to rupture or leak. Now, if you listen to, these are not my words, I did not draft that. This is the recommendation for better patient communication, and this is put forth. If you just listen to what I have said, one will look at the implants very seriously and say they are not overall safe devices. One of the patients that came to me today, she is the one who's scheduled for surgery on Tuesday. She said, I have implants now 14 years, and she has what is a grade 4 capsular contracture. And the point here is she could potentially have a rupture. If you look at the guidelines again, the grade 4 capsular contracture, just kind of a recap, is where the breast is deformed and painful, implant is palpable and visible. So as you can see, this is irritated, angry, painful, and deformed. And we do not know why this happens, but it happens when the implants are placed above or there's a biofilm that forms around the implant. And again, larger implant can cause a higher chance for capsular contracture. Again, the majority of the times you do not know why, but these are the supposed thought processes. The other thing I want to mention here is, this is from the Mentor advertisement itself. This is the back of the journal that we read, and you will see the same black box warning that I read earlier. And then over here, I will read, quote, MRI screenings are recommended 3 years after initial implant surgery, and then every 2 years after to detect silent rupture. And this is where the implants do rupture. They're not lifetime devices, and there needs to be adequate surveillance. You do not want to get an MRI and say, well, my implants are intact and I'm good for another 2 years. No, you could rupture next year. Maybe you could rupture 20 years from now. I reviewed a chart of a patient that is coming to me from out of town, and she has implants from 1982. And statistically, the fact that their implants are that old, she is 99.9% ruptured. And remember, she should have had them removed long time ago, decades ago. So please ask me any questions anyone may have. Mara, if you see anyone asking questions, please let me know.
I don't see any, but I know that muscle repair has been a very common topic lately among patients and potential patients.
Okay, so very good question about muscle repair. Now, this is a very good question to ask. Now, whenever the implant is placed below the muscle, the surgeon inevitably has to cut the implant, cut the muscle in order to put the implant below the muscle. So this is the pectoralis major muscle. So if you have the pectoralis major muscle sitting on the chest, no one cuts on the midline part, the medial part, or the superior part, or the lateral part. They cut at the bottom part. And then when they cut the muscle kind of, if you will, window shades up. It has to lift up. And if this is the implant, it's going to go underneath. Now, as the muscle contracts, because it's up, and let's say the patient lifts a gallon of milk, or they lift a heavy dumbbell, or they basically lift their child up, the muscle is going to contract down. And what happens is it pushes the implant down, and it bottoms out that way because there's nothing sturdy to hold the implant down at the bottom. Now, as the muscle contracts up, because it was cut, the muscle generally and typically is not used by the patient. That's why the bodybuilders get their implants above the muscle so as to not compromise their career. Now, over time, when the patient is not using their muscle, imagine the patient has implants below the muscle and then they contract or lift something heavy, be it a child or the gallon of milk, like I was saying, they're going to push the implant, and it's going to be an awkward feeling because they're going to have dynamic movement of the chest. And so over time, the muscle atrophies and it contracts up. So let me give you the analogy. If someone cuts their Achilles tendon, for example, the muscle is going to retract up, and 3 months later, 6 months later, you cannot take that muscle and reattach it back to the Achilles, to the bone. In a similar fashion, if someone's, for example, bedridden and they don't get physical therapy, their leg or their knee will contract down, and you cannot straighten the leg after 3 months. And so the same thing, the muscle retracts up, contracts up. Now, depending on how the muscle was done, so the same patient that had her surgery scheduled, has had her surgery scheduled on Tuesday, her surgeon was a non-board certified plastic surgeon, a general surgeon in this area, who has now been augmenting and probably gotten with 10,000 augmentation over the years. But I know, because of the patients that he has taken care of in their past, that I've taken care of his patients in the past, his muscle was cut in a way where I know I will not be able to suture repair it. The other patient that I did 3 weeks ago, and we're going to post her videos and pictures, her surgeon was an A+ surgeon who really took the care and effort and did it professionally, board certified style, and did not cut the muscle and put the implant below the muscle. And she overall did amazingly well because her muscle was intact and pristine. And there are plenty of times where I repaired the muscle because it was cut in a very nice, systematic, thoughtful way by the board certified plastic surgeon who did the implants. So the patient that had the implants, that was the 695, you can imagine such large implants that's going to push the muscle all the way up. When I remove the implants, the muscle you cannot take and basically reinsert at the origin. And so in her, no matter what, no plastic surgeon on earth can repair her muscle and basically put it back to, and remember, all these years that her muscle was cut, she was never truly using the muscle, because the muscle would then compress against the implant and the implant would move and be dynamic and the patient would feel awkward. In a similar analogy, if you put the implant below your thigh muscle and you ask the patient to run, you're not going to be able to run because the implant is going to move up and down because the muscle is going to contract against the femur. In a likewise fashion, the implant is sitting below, and over time it just moves down. And if you contract the muscle, you push the implant downward and outward And this is where the implants only gravitate down because there is nothing sturdy. So depending on your surgeon, depending on the size of the implant, depending on how your surgery held up, the muscle, if it can be repaired, I definitely wholeheartedly, sincerely repair it, because you only need it not only for function but for aesthetics. But if your surgeon cut the muscle where it cannot be repaired because this was the bad job that he or she did, and because of the way that your malpositioned implant basically held out over time, that muscle, no matter what, cannot be repaired. You cannot suture the muscle down, and then when you contract, it's what are you going to suture it down to? And so this is basically where it will not be able to be reinserted at its origin. And so this is basically the defined answer that I have. And this is very much the standard that any board certified plastic surgeon will tell you. So how can you tell a gummy bear implant is ruptured on an MRI? So that's a very good question. You will see what is a linguini sign. You can Google this. Linguini sign, will you see irregularities? You can get an intracapsular rupture. You can see an extracapsular rupture. You can see silicon granulomas in the proximity. You can see fluid around the implant. So clearly, there is the best test that is out there in 2025 is an MRI without contrast. So it's magnetic resonance imaging, no radiation, no contrast. So it's a very safe test, and it will tell with good certainty. It's not a 100% correct test. One day I operated on two ladies. On the first lady, it said MRI said the right implant is ruptured, and when I did the surgery, the right implant was intact. On the second patient, the MRI had said that the implant is ruptured, and lo and behold, it was. It said that the implant was ruptured and it was intact. So it was wrong in both the ways. And the point here is, it is a fairly accurate, the most accurate test, but not a perfect test. Remember, the ultimate way is when the surgeon goes in and removes. So mammograms are meant to pick up on calcifications for breast cancer. CT scan is not the way to doing it. It's too much radiation. So the MRI without contrast is the ultimate and the best way, but not the perfect way. I do not mandate an MRI on everyone because I assume all the implants are ruptured till proven otherwise. Only in those small subset of patients that had a first set of implant that was ruptured, and then the surgeon cleaned it out as best as he could, and then put in another implant, I want to be able to remove in this patient that second set, which is an intact implant, if it was recently done, and that history of spilled silicone. I want to find those pockets of silicone deposits in the periphery, and the MRI helps me direct my surgical care, and by visualization, palpation, if I find anything. And sometimes what surgeons do is, if the implant migrated down and hid in a pocket, and then the surgeon sutured that pocket, I do not want to miss that pocket. And this is why the MRI is key for me to help me. As I go in, I know where the silicon granuloma or these masses are, and I can target them in addition to my visual and palpation, and anything inflamed, I remove.
I have a question, Dr.
Yes.
Khan. How urgent is it that you remove a ruptured implant?
So this is a good question. You know, if you look at a ruptured implant, and if you look at the videos that I have on Facebook, there is an urgency, because if you have an intracapsular rupture, you do not want to make it an extracapsular rupture. You will see patients with saline implants have had lymph nodes laden with silica in them, intact saline implants. We have reports of patients with silica in their lung from a lung biopsy for other reasons, and they concluded it was from the silicone shell of the saline implant. The silicone implant intact, gummy bear, that nicer, better, safer, it still leaches out silicone particles from an intact. A ruptured silicone implant will impart more particles because there is no true shell that's holding it together, more so than an intact implant, be it saline or silicone, because of the way it is ruptured. And you can see, if you have a ruptured implant, how the slimy it is and how angry and how kind of molten it is. If someone has a ruptured implant, you need to, I will tell you, I would want to get it out the same night. So there are patients, because the patients, it is not healthy or wise to have that silica migrate into the periphery. And it is not healthy to have silica inside the chest cavity. Otherwise, why would you want to get an MRI at year 3 and then every 2 years they're onward? Because this is like kind of an interesting catch, and this is, if you ask me, this is again on a mentor ad, not my words. Anything that I have said today is not my words. It's just kind of bringing out forth what is the obvious and the objective evidence. So over here they say, quote, the health consequences of a ruptured silicone gel-filled breast implant The health consequences of a ruptured silicone gel-filled breast implant have not been fully established. Close quote. And then let me quote as well, MRI screenings are recommended 3 years after initial implant surgery and then every 2 years after to detect silent rupture. So they're telling you the health consequences are not well understood. I'll tell you this, if I take a ruptured silicone implant to a third grader and I tell the third grader, would you want this inside your body? They will want to not even say, what is this goo? They do not want to even touch it, let alone the silica that basically is now leaching into the periphery, more so now because that it is ruptured. The other thing I want to highlight here is, so anyone will tell you that it is not healthy wise. Otherwise, why would we want to be getting a MRI at year 3 and every 2 years there onward? The other thing I want to mention here is, and again, this is all according to the same initial guidelines by the Guidance for Industry, Food and Drug Administration. It says over here, quote, page 14, patient initials. I understand that all breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of the implant, but small quantities have been found to diffuse gel bleed through the implant shell of silicone gel-filled implants, even if the implant is intact and not ruptured or leaking. A list of these components, chemicals, and heavy metals is available in the patient information booklet brochure. And as I go to the next page, in the next set of pages, it tells me over here, page 18 and 19, what is heavy metals found in breast implants? Arsenic, barium, beryllium, cadmium, chromium, cobalt, copper, lead, magnesium, mercury, nickel, platinum, selenium, silver, tin, titanium, vanadium, zinc. So if you have a ruptured implant, if I knew I had a ruptured implant right now, I would not feel comfortable having it in me. And this is very appropriate if you ask me, because why would you want it to diffuse into the periphery and then affect the other tissues? So a small subset of patients that have ruptured implants, and now you remove the ruptured implant, guess what? There's lymph nodes that have silica, liver has silica, not in all. And if you look at the studies of Dr. Henry Dykman, where they looked at a patient who had ruptured implants, and then when she passed, and God bless her soul, she donated her body to science, they did biopsies of different tissues like the spleen and nerves, and they found silica at different concentrations. And this is absolutely consistent with what I just read. Not my words, these are objective documentations by the FDA. So this is not healthy. And you know what they talk about, silent rupture? Silent rupture on the MRI screenings means that you examine someone, the exam looks perfect, amazing results. I go into the surgery and lo and behold, it's a ruptured implant. And you would think at least the patient would complain of pain. No, it's a silent rupture. No, if you bring 10,000 plastic surgeons and examine this patient, they will say, excellent result, good job. And this patient has a ruptured implant, and this is the silent rupture. Most of the ruptures are silent. So there is an urgency into it because you do not want to make the intracapsular, extracapsular, you do not want silicon granulomas, you don't want more spillage, and you want to contain the fire, if you will. The other thing I want to mention is one patient came to me and she said, I have a normal MRI, I'm very happy. I said, maybe next year you might have a rupture. Maybe 10 years later you might have a rupture. So you're playing Russian roulette or musical chairs and your time will be up. And remember, at the 10-year mark, plus minus, the time has come for you to replace. Smart person would remove completely and do it in an en bloc fashion. And I want to go ahead and see if I can answer another quick question. Is it more difficult to remove a ruptured implant? Absolutely. It's a bigger fire, more explosion, more angry, more irritated, more bad, more everything than compared to an intact implant.
I have a question as well, Dr. Khan.
Yes.
How do you know if the implant is above or below the muscle just by looking at it?
No, you cannot. So this is a very good question. So if I have 1,000 patients that came to me, 950 of them statistically will be below the muscle, because any good, reputable, board certified plastic surgeon will be putting the implant below the muscle. Less contracture, less chance for infection, less malpositioning, less everything. Let me correct myself. Any good board certified plastic surgeon in 2025 would not be augmenting. But if they did, they would be placing it below. So putting it above, you cannot tell on physical exams. The only way you can tell, or there are three ways you can tell if it is above or below. Number one, you go and see the operative report from the surgeon who did it, and he will tell you he placed it above or below. Or you get an MRI, and MRI tells you if it is above or below. Or on the day of the surgery, when the explant is done, and the patient and the surgeon tells you it was above or below. Over the muscle, definitely easier, because then the surgeon is not dissecting on top of the rib. Remember, this is the hardest part of the case. I find it extremely hard how many surgeons make an up and down cut and cut parallel to the rib. If you ask me, that is a very hard surgery. And so for exposure purposes. And so I want to see the pictures and the videos of the chest wall showing complete removal. This is the new and the objective evidence. Now that a lot of surgeons are doing explants who claim to be the world experts, I don't want to hear anything from anyone. I just want to see the high definition pictures and videos of the chest wall showing complete removal of that capsule off of the rib, which is indeed what is the hardest part of the case. What if you had explant but doctor didn't get all of the ruptured silicone? I'll tell you, then you have residual silicone by default floating around. Imagine you have a slime in a balloon and you're removing the balloon intact. And if there's any break in that balloon and the slime spills, you're going to see that it's going to spill into the periphery. No matter how much you wash it out, you're going to spread it out even more. It has to be done in a very thoughtful and sophisticated way. I see, I went and looked and typed in Los Angeles explant surgeon. I was shocked how many explant surgeons there are, and they're claimed to be the world experts. And I find it very positive that a lot of surgeons are now doing explant surgery. You will see they're using the word en bloc, they're using the 100% excellent. If I'm the surgeon and I want my patients to ask me, show me the video and of the chest wall showing complete removal of the capsule and the implant, such that there is no inflammatory burden left behind. Ultimately, what seals the deal, if you ask me, is your surgeon is not doing any augmentation, because in any surgeon who gives up augmentation, it takes 1 hour or less to do an augmentation, where it takes me 4 hours to do an explant. It is not only the time, but the physical endurance of doing the surgery. It's a tedious and involved surgery. And then you have to be able to, number one, not only be convinced that you have to get the whole capsule out in the en bloc or the 100% whole capsulectomy. Number two, you have to be able to deliver the surgery, meaning perform the surgery in that manner. So I find many surgeons who even want to do, when the going gets tough inside the operating room, they basically cut corners and they leave the capsule behind. The other thing I want to mention is, when the implant is placed, usually it's 2 or 3 finger breadths below the clavicle. Majority of the implants move down over time. And when the surgeon removes, they remove the capsule here, but not all the way up. So that whole entirety of the capsule needs to be removed. I want you to go to my YouTube page and under shorts, and I want you to see the high definition videos of the chest wall, where you see the capsule spread all the way from the medial side of the chest all the way to lateral, and you'll see the spread of the capsule that has been completely removed.
I have another question, Dr.
Yes.
Khan. Where are we located, and how long do patients have to stay in town if they're from out of state?
So this is a very good question. We're in Bloomfield Hills, Michigan, and the patients typically come in on a Monday to see me in clinic. 8 or 9 out of 10 patients, so that means 80 to 90% of my patients come to me from out of town. They travel, they fly, they drive. I've had many patients from Europe, from New Zealand, from India, and you can see this on the Facebook Live. And it is very safe to travel. And so they would come in and see me on a Monday in clinic. Monday, we basically talk, we discuss, we go over the last set of questions, last minute details that we have about the surgery. Tuesday, the surgery happens. Tuesday, you recover. Wednesday, Thursday, and then Friday, you see me in clinic, and you basically are back to your home state, to your hometown, so that I can then follow you very definitively from the comfort of your own home. As far as DVT, which is the deep vein thrombus, I give every patient heparin sub-Q. Everyone wears compression socks to surgery. Everyone is out of bed to cheer the day of the surgery, and the following day, they're ambulating and walking. Everyone gets what is pretty much what is twilight deep sedation. They're not paralyzed, so the chances for forming a clot essentially minimal to none in that form. And if you look at this, this is a very smart, wise way of preventing clots, especially with the many patients who are traveling or driving. And when they go back to their home, only then do they remove the compression socks. And as you will see, this is a very well tolerated outpatient surgery and very comfortable. This one patient that I saw today, who's going to be getting her surgery on Tuesday, believe it or not, she lives 45 minutes away. And she bought her day without even talking to me because she had done her homework. She's a school teacher. She's off for the summer, so she's prepared for surgery. And now she's going to recover before the school year starts. So there are patients, another patient that I talked to this morning from Indiana, she already bought her surgery without even talking to me because she knew exactly what she was signing up for. And this is part of the informed consent. So I want you to do your homework, do your research, ask questions, talk to 1, 2, 3, 5 different plastic surgeons, and I want you to get that comfort feeling that you are making the right decision. Most of my patients, if not all, are very excited about their surgery because they know their good health awaits them. And you have to do your homework. The same patient that's going to get her surgery on Tuesday, if I may use her as an example one last time, had she gone to the top 100 hospitals in the country, believe it or not, she would have been told, remove the set and we will get you another set, so that when she is 52 or 55, she would now need to then remove it. And this is where you want to know exactly what you're signing up for. So there you have it. This is Dr. Khan. I'm going to be doing another Facebook Live on Monday, very likely early in the morning, so that please feel free to ask any questions. I'm going to do it regularly and routinely. If you have any questions, please write them down, send them to us, and I will answer each one of them. I will be the first person to say, I do not know if I do not know, but one thing is absolutely certain. We have a lot of objective evidence from the 1992 ban, from the many patients who are complaining and hurting, who have benefited and improved. We have a lot of objective evidence in the literature from the previous history of the ban. And if you just listen to the patients, and I'll certainly end with this, my patients almost always, if not all the time, have said two things. They wish they had never gotten an augmentation, and they wish they had removed the implants sooner. That tells you a lot about a surgery that is, in my mind, ultimately only bad. Do no harm. This is Dr. Khan, Executive Plastic Surgery.